So welcome, sir.
Good afternoon, everyone. At the outset, I'm really thankful to Ferty9 for calling me up. And it's a huge crowd, I am seeing after a long time after the ESR conference, what we had. Welcome all my panelists and my co-moderator, Apurva, I'll call her up here. This is regarding, we'll do just a case-based discussion. What actually, we don't go into the literature reviews, and we will be pertaining to what we do it in our clinical practice, we'll talk about. Yeah, so the question is, she's 28 years, married 4 years, irregular cycles with the severe dysmenorrhea, has 3 failed IUI cycles. Do you feel that if the IUI, what we gather the information prior to the IUI, the tubal testing has to be done, and all that thing has been done, and she has 3 failed IUI cycles. Do you feel the role of the diagnostic laparoscopy should be advised? And what is the pre-operative counseling you will do, and what is the mode of the treatment? Because if she has been done the ovulation induction cycles, anything else you wish to ask to me, what details, things you need to ask about this patient, because she's 28 years, 4 years of infertility, irregular menstrual cycles, and 3 failed IUI cycles. Anyone can answer, it's not like...
To go ahead for a diagnostic laparoscopy because she has complaints of severe dysmenorrhea and 3 cycles of IUI have failed. So probably we should be looking to see if there's any endometriosis in this patient. So preoperative counseling definitely is required because we have to counsel, we have to see, and she has irregular cycles as well. So if there's any PCOD also, we should be counseling her that we may proceed and do a drilling also.
Any other history you wish to ask me, like prior to the laparoscopy? Because see, if she has undergone 3 IUI cycles and which has been failed, before going into the diagnostic laparoscopy, any other history you wish to ask? Like you directly, male factors, okay. For male factors you will implode on. Yeah.
IU has been attempted. So we will go back to see how was the pre-wash and the post-wash sample. Okay. Probably that should be...
So before going into the diagnostic laparoscopy, you wish to talk about the male factor evaluation. So already because the 3 cycles are been done, what we take home message from Dr. Rajiv that more than 4 IUI cycles will not increase the success of IUI. Correct. So that comes down to the one boiling point that whether we should go with the diagnostic laparoscopy or not. So in your routine practice, do you take the consent of the diagnostic laparoscopy, or maybe it is always a diagnostic with the operative laparoscopy per se?
Yeah, but the both has to go in hand. There is no time for us to wait because 3 cycles of IUI has been failed. So mode of treatment will be find out, scan findings should suffice about relatively any endometriosis, any tubal factor involved. Based on that, we will go.
Definitely. So if on the diagnostic laparoscopy, you have done the diagnosis and this is the picture, you find it out. Yeah. So at that particular point, you call the patient's relative into the OT and talk, this is the picture and this is the modality. What the modality of treatment you like to go in this particular case? That if she is having the grade 1 endometriosis, you can see that there is a peritoneal endometriotic implants. So what is your, like as a laparoscopic surgeon or maybe a infertility specialist, what you will talk to the patient?
Go ahead and do the ablation. We have to go for an operative laparoscopy and first of all
restore the anatomy and the recurrence for grade 1 endometriosis to recur, and the ovarian tubo anatomy can be distorting at any point of time. So we have to be a little quicker in giving her the fertility management because 3 IUIs has been done. The next mode would be not waiting much, and then we can advise another level of ART if possible.
So in general, when you're talking about the diagnostic laparoscopy, you find it out there is a grade 1 endometriosis. Whether you're still going to do an ablation or the peritonectomy, because nowadays there is a laparoscopic surgeon, they come up with a different thought process, and IVF consultant, they come up with a different thought process. What are the precautions, if at all you wish to go with the ablation? What is the management you would like to do? Or if you were going to do a total peritonectomy, whether it is really going to help for the patient or whether it is just a boon in endometriotic surgery?
I
Yes.
think ablation is sufficient for this grade 1 endometriosis because there is not much
There's no much difference
Anyone?
between.
Yeah.
Endometriosis is a recurrent condition. Whether you do ablation or you are doing that full peritoneectomy, the patient will be having recurrence rate. So instead of doing peritoneectomy, if it depends on how far the endometrium.
Yeah, this is the real
peritoneum
picture. So what
for only
we
this
had.
picture concerned, we can do only ablation and checking the male factor part. And endometriosis per se, it's a progressive disease. Now only the peritoneum is affected. In further coming years, she may be having ovarian endometriosis also. We have to rule out how the AFC and AMH also for this patient. Depending on that, we'll counsel. Definitely when you're doing a laparoscopy, we have to counsel them prior-hand. In case if anything is required during the procedure, we are going to do therapeutic procedure also during the OT. So we will take the consent beforehand.
So we'll just ask to the audience, there are the two school of thoughts. If you can just do the Facebook or anything, the people there are doing a endoscopic surgery, they will do a total peritonectomy. And those who are doing a fertility preservation will do a ablation of the implants. How many of you think that the total peritonectomy will be helpful for the patients? Because there are the two school of thought in here, like the peritonization occurs in 48 hours. So do you believe in total peritonectomy will be a ab treatment or just ablation? And after that, what is your course of treatment? You will do a wait and watch, or you do a control ovarian hyperstimulation and IUI, or what is your protocol? Because here the factors now of failed IUI maybe it could be because of the endometriosis. Yes.
We don't wait and watch, sir, because it is an endometriosis. It will be progressing day by day. So we don't wait and watch. Obviously, we will be doing active treatment itself. So it is a grade 1 endometriosis. Whatever the necessary treatment should be given, it has already been given. So better we should counsel the patient for the ART.
Yes.
Treatment.
Here I wish to quote one beautiful event that usually happens, that if our endoscopic surgeon is doing the operative, he will always go for a total peritonectomy. My friends, when you do a total peritonectomy, it's not a standardized treatment yet. Because what is the proportion that what they're talking about, you have to take the disease out. But the endometriosis, you never know what is the recurrence rate. So it is better in which peritoneum it has been affected, whether it is a nodule or it is just a multiple spots, that is a cherry spots what you are seeing in a laparoscopy, or if it is a nodule. If it is a nodule anywhere, then definitely it has to be excised. And if it is just a peritoneal, what you call as a early endometriosis, because endometriosis has two lesions. First is a pink lesion and then you have a fibrosis. If you see at the fibrosis, then it is definitely old endometriosis. It won't be get curatized, whatever you are going to do. It requires a restoration of the anatomy, and then what rightly said by her, it's you required a COH in a later half. Considering the same, if she is not going for the laparoscopy, what is the line of treatment you need to offer? Because the early endometriosis is not going to get diagnosed. If it is a endometrioma, definitely it's going to get. So if there is an endometrioma and she doesn't want to go with the operative procedures, what is your...
Endometrioma, not necessarily what we need to go for an operative procedure. Endometrioma less than 4 centimeters can be left alone without any operative procedures before any other treatment we follow. Rightly, if the follicle is
but
not...
endometrioma 4, along with that, you will consider something that is only the endometrioma 4 will be my cutoff, or maybe along with that, it is the age of the patient, duration of infertility.
Age of the patient.
Symptomatic or not is also important. If the patient is symptomatic, she requires...
So any symptomatic endometrioma, definitely we need to have a surgical management. If at all you wish to go with the endometrioma treatment, for that matter, you have done this is a endometrioma surgery on the endometrioma of the ovary. What precautions you will like to take as far as the endoscopic procedure is considered? And pre-operative evaluation of AMH is good enough to tell the patient that my success of the surgery, because if she is coming from the IT background, she know that my AMH you have to do it because there is ovarian endometrioma. The endometrioma itself causes a poor ovarian reserve. And I will do the endometriosis surgery with you. What is the impact on the AMH to me?
Yeah, because all are very well known about AMH. So right now, before Definitely, before we put a port, first indication would be the pain. Dysmenorrhea is the first indication that we need to put a port, irrespective of endometrioma size. And definitely, AMH has a greater impact before we go and do any kind of endometrioma surgeries. And we should be very careful that we do a blunt dissection rather than using any other cautery, so that we are preserving the cortex of the ovary, so that the follicles are maintained.
Anyone
Cystectomy
else?
needs to be done. Cystectomy, no ablation, no incision drainage. And,
So when you do a cystectomy, my friends, the chances of normal ovarian cortex is going to come up. What are the techniques? Even if we are the best endoscopic surgeon, you never assure that the particular ovary is not going to get damaged. So if I do a AMH retesting again, how many months after I will ask the patient if she wants to do it AMH and assess your surgical skill?
Yes.
So after 6 months. Anyone else wish to differ about it?
After 3 months?
Yeah. And if after the 3 months, do you think the AMH will be, if it is a 2.5, come down to a 1.6? So she will be after you that because of your surgical procedures, my AMH will go down, and what you will counsel to the patient?
It may not be entirely due to my procedure because endometriosis itself is a destructive type of
Yeah,
disease.
but madam,
So
you had
because
done the
of that
laparoscopy
also-
for the completion of the procedure. So she will say, you had done my complete procedural completion of endometriotic surgery. So how my endometriosis again in 3 months causing the AMH down? Yeah, perioperatively she said, no, okay, fine, it is a 3.5. Suppose that time it was 3.5. You advised her 3.5 is a good ovarian reserve. She accepted for the procedures to undergo. And after the procedures, the AMH comes down after 3 months. Because it's usually a clinical scenario what we find it out. And then what is the take on that particular patient? How will you counsel? And what is the next line of a treatment? Yeah, no, you can reassure her. But what is the reassurance that you will
Still not
do?
into a poor ovarian reserve. We can still reassure her because she's within the limits of AMH. Definitely, that would strike in an OPD.
See, why I ask this question, whenever you are going for the cystectomy, the standard of care of a cystectomy is not only the drainage. When you do a drainage in a particular patients where there is age is advanced, AMH already been poor, and she's symptomatic, endometrioma. In those, only a drainage will be a possibility. You will not do a cystectomy. But if the AMH is good, she is young patient. What I mean by the good is a normal responder, or the AMH comes into that range. And if she is a younger patient, you do a cystectomy. But you need to assure that when you send the cyst wall for the pathologist to diagnose, it is not an endometriotic cyst wall. You have to see how much is the cortex is been come out. So whenever you have to give the report that these are the particular things that have been come out, and these are the ways what we are. And after the 3 months, you have to talk to the patients. There is a definitely decrement in the AMH, and that's why I will be selecting the patient in whom the patient is young one, patient is having the normal AMH, and a patient is also having the symptoms. Then and then I will operate. Otherwise, I will not operate pertaining to that of endometrioma. And if at all she is a symptomatic with the older age group with the low AMH, I will operate, but I will just do a drainage. I will not do a cystectomy if at all she is symptomatic. If she is not been symptomatic, I will just do a directly IVF because she is an older age patients. We know the AMH is low. It is better to go with the IVF protocol. So if at all she refused to go all these discussions and she said, I don't want to go with the surgical exercise.
It's a best decision, that too, because definitely endometriosis dictum is recurrence. So minimal handling, definitely we'll go with the AMH values and then accordingly. Direct going to IVF is also can be done without a preoperative.
Okay, so my questions from this side. What is the ideal protocol in endometriosis? Stimulation. We'll go one by one fast, and then we'll go to the live case that anyone has given to us from the delegates.
We can go for antagonist protocol, and some people may prefer down regulation and then give
What is your choice of protocol? Is
Usually
antagonist
I
protocol?
go with
What about you,
antagonist
madam?
protocol.
Yeah. What about you?
The low AMH is low, we'll go with the mild stimulation protocol and definitely antagonist
Okay,
protocol.
so mild
itself.
stimulation, antagonist.
antagonist.
What about you, madam? Antagonist. Okay. If you do any pertaining to the dose, you start with the higher dose. As Jatin said, should be a 250 to 300, maybe a 450 or maybe higher.
So, patient with endometriosis, we give 75 international units higher than what we normally decide for that patient.
Why you thought of giving a higher dose of 75? Because she is endometriosis.
So, some risk factors we generally tend to give a higher dose, an additional dose.
Okay. So if the patient is normal, you start with the 150. If the patient of endometrioma, you thought of giving add a 150 plus 75 to 25.
Cystectomy,
No. It's the endometrioma. What is our case is 5 centimeter endometrioma, asymptomatic, but having a poor ovarian reserve. So we start off a stimulation. Both of them was started about antagonist. She said, okay, I will start with the short protocol. You start with the 75 units of a higher. See, why I wish to ask all of them, you need to understand when we are IVF consultant, we thought of a different angle in a different ball set. The patient is the same. They are both are talking of a different protocol. She is talking about increment of the dose. We'll have the third panelist here. I will ask, okay, you increase the dose and you have the follicles which is generated on 5 follicles on the 7 on the right side, 4 on the left side with the endometrioma. What is your trigger?
I would like
Antagonist protocol and if short flare-up. Yeah.
Okay. I would like to add LH also from the beginning, maybe according with the recombinant FSH. And then coming to the trigger.
Okay, now see, here is the again dilemma. If you wish to have, any one of us are here endocrinologist, proper endocrinologist, DM. In endometriosis, we have a 2 LH, that is called as hump. We have a bilateral hump in LH. If she wished to start the LH from day 2, her oocyte quality will not be that appropriate. So that is the first thing when you're talking about the LH in endometriosis. And the oocyte quality, there is a different, altogether papers also, when you are oocyte quality, whether it is hampered in endometriosis or not. Now recently at 2022 papers, they said that the oocyte quality doesn't show any of the changes. What it will show you are the number of eggs retrieved as compared to the which of the protocol. So I'll come down to the 2 ladies first. The short flare-up and antagonist. I think I will not go with the antagonist protocol, madam. Somehow I will not liking it. And current literature also doesn't like the antagonist protocol in endometriosis. Can you counteract me, because we have a healthy discussion, it's not a panel.
If I look into the synchronicity of the follicles, if she is having a low reserve with endometriosis, where there is a high chance of asynchronous cohort, then I would definitely go with luteal phase agonist and then synchronize it, long protocol what I can say. If at all she's a young patient, good reserve, and then there is always
she's a 35 age, 5 centimeter, endometrioma, married for 2 years. And that's why we are doing with the stimulation protocol. Surgery, she said, I don't want to go with the surgical. So we come down to the IVF protocol. So in this patient,
with good reserve,
yeah.
yes, sir? Good reserve, and still I can go with antagonist.
Okay. So mind well, my friends, when you're talking about the protocol, is a agonist or antagonist protocol, why I'm not happy with using an antagonist protocol in this particular frame of time? Because agonist itself is a treatment policy. Secondly, I know the chances of gonadotropin injections will be on a higher side. I do understand that. But mind well, friends, when you are talking about agonist protocol, the chances of M2 retrieval is on a higher side as compared to the antagonist protocol. So I wanted these patients to give me a M2 oocytes on a higher side, because in my mind, when you're talking about endometriosis patient, there are the 2 things will happen. The M2 oocytes, even if it is a M2, the mitochondrial contents of the M2 oocytes is on a lower side. So even if I do the ICSI or maybe IVF nowadays, what Jatin was talking about, is a similarly success rate, but I wanted to have a blastocyst formation. So if I have a M2 on a higher side, my chances of blast formation will be higher. The chances of ongoing repeated IVF cycles are higher. And that's why I will not be little bit disagree. Okay. You may have an antagonist protocol to follow. Pertaining to the another panelist, she talked about the LH, whether I should be adding the LH from day 2. Here the endocrine system plays a role. When you're talking about the LH in certain situations, If the LH in PCOS, the PCOS is a different phenotype A, B, and C and D. I will not go into that. But in endometriosis, pertaining to this case, the LH has a double hump. If you see the LH of the endometriosis patient is always in the middle, it is high, and in the day 2, it is high. When you start stimulating the patients, you do it by yourself, you will come to know. So if initial LH is high, that's why we don't want LH high in our stimulation. What is the rule of 5? The LH less than 5, progesterone less than 0.5, and E2 less than 50. Why we talk about that down regulation? Because initially we required the FSH receptor sensitization, and then the LH comes into circulation. Similarly, if you have the LH on higher side, what she was talking about, adding of a little bit LH will cause detrimental effect for the oocyte quality, which is, we don't want the endometriosis to happen. So coming down to the trigger, so trigger, definitely you use a dual trigger, or maybe if it is an agonist cycle, definitely SCG is the gold standard. What are the precautions you will like to take when there is a 5 centimeter endometrioma and you are going for the pickup, or a gynecologist sent you the patient with the stimulation, and she has clearly given the note, there is a 5 centimeter endometrioma on the left side, and then there is a cyst follicles. So what is the precautions? Any anesthesia, any antibiotic, any needle changes, everything we can talk about. Yeah. We'll give a chance to, yeah, you can. Because all of us are colleagues, so it is better that we should discuss rather than asking questions.
During pickup, we should not injure the endometrium. We should not puncture the endometrium. Then post-operatively, we have to give injectable antibiotics.
Anything else? Yes.
Even if we puncture the endometrium by accident, better we take out the needle and better we flush it with the media. And then we can reinsert and then aspirate the follicles to avoid the detrimental effect of the endometriotic fluid. It will affect the whatever oocytes we are going to aspirate next.
So you will finish with the normal side first, and then you will come down to the endometrium.
We'll start
so
with the
anything else?
first.
You inadvertently do the puncture, and your andrologist or maybe a embryologist said that it is coming up with a brown color. So what you will see? You wanted to flush the needle, or you wanted to change the needle?
Generally, we flush it, or if the material is very thick and the needle got stuck, then we'll change the needle and we'll start with a new needle.
Okay, now we'll go, whatever precautions you had taken, and on day 2, she had come down to you with the pain. The patient may come, no, because it's a live situation I'm talking about, not hypothetical. So what is your first thing in your mind? Because you had sent the patient again to her gynecologist, and she just called you up. She said there is a patient is complaining of pain on the left side again. On the right side, she's pertinently saying that there is a pain on the left side. So what is the first thing you ask the fellow to do it? Which investigations or you are thinking of?
To rule out any ovarian torsion because of that.
Infection.
Endometriosis and torsion, I will not keen about, because endometriosis, fixed disease, peritoneal adhesions, torsion.
We have to think about any abscess, ovarian abscess. Is there an infection?
Abscess. Yeah, in your notes you are saying I given the antibiotic, I changed the needle, all that thing you are written it down. Anything else? The patient coming, no, and
so
you have to.
It's a case of endometriosis. She will have a day 2 pain mandatory.
Day 2 pain? No, she's not day 2. No, she's day 2 of pickup. She's not day 2 pain. So she's definitely that is a pain is.
Day 2 of pickup.
So we should ask other complaints also, not
Yes.
only pain.
Fever.
If she's having any fever, lower abdominal pain,
Yeah.
then we have to do pelvic examination. In pelvic
Yes.
examination, we have to see the tenderness in both the fornices.
Usually on day 1 or day 2 of pickup, every patient's complain. I think Jyoti will say they will complain of pain, because whenever you do a TVS also, they will complain of pain. So it's fine. She'll complain of
If
pain.
any pelvic abscess, definitely it is associated with temperature.
Yes.
Then we have to do investigations to see the WBC count.
Yeah. See, why specifically I talked about day 2, there are the 2 complications. Even if the endometrium is not been infected, there is a peri-endometrium. I have that beautiful video, I'll show it to you. There may be a bowel adhesions, peri-endometriotic tissue. And if you damage the things, usually it is a mechanical injury. The thermal injury, what we used in a harmonic or maybe a bipolar sharer, comes after day 5, day 6. But whenever you have an injury of the bowel or maybe a visceral structures, it comes on day 2 or day 3. And the patient will have a pain with the tachycardia and maybe a feverish symptoms. Then you have to go and investigate later on. So she's now perfectly all right. She came down to on day 2 of the next cycle. Whether you plan, you are already planning for the FET. So what is your protocol? You will give a pre-treatment generation analog, or you will just do a fresh ET, or you will do operate again and then do a generation analog and then the FET. Endometrium is still there. Yes. We'll go from that side, yeah, because I think we'll cover all of you. He's andrologist, so I'll come down to that question once our. Yeah.
So, not going for the surgery, definitely not. Better to start with the agonist protocol. Means down-regulated protocol. Will start with Lupride injection, and after that.
Madam, there is a two things which as a patient I'm asking. I'm having an endometrioma. That endometrioma is still there. My embryos are with your bank. So embryos are already been cryopreserved because I had symptoms for 2 days, a little bit pain and fever. Thank God I'm not landed into any abscess and anything. So everything is fine. So now I'll come down to you on day 2 of my period, and what is your, because endometrioma is there, as you mentioned, everyone, my referring gynec also told me that I'm having a endometriosis. I read with the literature, with the endometriosis, there is always a chance of spontaneous rupture in the pregnancy also. I have every literature in my brain because I'm a Google person. So it's what is your thing that you will talk to the patient, because this is a real live patient. So whether you wish to give a Lupride agonist, I know Lupride agonist causes a decrease in the volume reduction is doubtful, but symptomatic relief is there. I definitely read that also. So if you give a GNH analog, or whether you will post me again with the surgery and then do a ET, what is your thing in that case?
First, we'll see a scan and we'll see whether the endometrioma size has increased or not. If she has any more complaints like
No, nothing. I'm day 2. I'm very much fine. I don't have any complaint, madam.
And if the endometrioma size is like the same, so then we'll definitely post her for the ET this cycle.
So this cycle you will do the ET preparation and the
followed by the Lupride protocol.
Any one differ from that?
So because patient is having pain, patient is symptomatic.
No symptoms. That symptoms was there day 2, and that is gone.
Dysmenorrhea is also not there.
No, dysmenorrhea is there because I'm used to that, because it's a day 2. I'm knowing that there is a endometriosis, so dysmenorrhea is not it's a chronic complaint for me, no? So it is not pertaining to this procedure now.
So my perspective, I would like to do an endometrial preparation first. I would like to see what is her endometrial thickness coming, whether the triple line is present or not. If everything is good, if the patient is asymptomatic, I would like to go for transfer. In case triple line is not coming, if the patient is not having good endometrium associated with a 5 centimeter cyst, I'd like to do diagnostic laparoscopy with hysteroscopy, remove the cyst, then again go for embryo transfer.
Okay, what is your opinion, madam?
And if the patient is asymptomatic, I'll go for endometrial preparation and transfer, sir.
Okay, I'll go. I run from 5 centers, 1, 2, 3, 4, 5, and now 6. Yeah.
I will give GNRH analog, and next month I'll go for.
So you give one GNRH analog and then, yes, madam.
I would like to prepare her endometrium, and if it's good enough, I will definitely go for transfer.
Okay, now I'll again go, because the 6 centers tell me 3 opinions. I'll go and Google myself and come back again. And I'll come to know that endometriosis is having interleukin 1 and interleukins that is been on a higher side. It is an inflammatory process. So I'll ask to the center 2 and 3 where I gone again for, they said you could just come back. I'll do the FET in your case. So I'll give it the reports that the recent studies shows that there is a intermolecular changes, inflammatory reactions on a higher side, and when you do the pickup, your inflammatory markers always on a higher side. So I'll just come with the page saying, so I'll go with this madam, because she's saying that you take a rest for 1 month with GNRH analog. So what is your take on that, madam? Because you are asking me to do the FET immediately. I will say no, I will take a break because my interleukin 6 and 8 is on a higher side inflammatory markers, and that will cause a compromisation in the implantation rate. That paper is with me.
Actually,
on
definitely for these endometriosis patients, we have to counsel before that implantation rates are comparatively less than the other patients.
Yeah.
So we have to counsel them for lower implantation rates, and we have to prepare the endometrium, and we have to see whether the endometrium is coming up Usually I like to go with the down-regulated protocol only, FET. So first I'll give agonist and then see in the next cycle I'll do FET.
Yeah, because initially they wish me to undergo the transfer on the next cycle. So I come and Google, and then I found out fresh and FET with the agonist protocol. So it is better that what I find it out on for 2001-4 retrospective analysis of the data, that even if you give a GnRH analog for 1 or 2 cycles and then you do a FET, the chances of pregnancy is on a higher side. So I request my co-moderator to be here, and we'll have one more case of those who are written it down on the page. Yeah.
We actually have a couple of questions on endometriosis itself. So this is similar to what Dr. Ashish has said. A 36-year-old married lady, married for 13 years, bilateral endometriotic cyst and fundal anterior intramural fibroid. The right ovary has an AFC of 7, and endometriotic cyst size is 2 into 2 centimeters. Left ovary has an AFC of 3, and the endometriotic cyst size is 5 centimeters. What should be our next step? Quickly we'll talk. We'll not ask about explanations. Madam, we can start with you. So she is 36-year-old, married for 13 years. Let's assume normal male parameters.
Straightforward endometriosis case, bilateral endometrioma, AFC 7 plus 3, 10.
5
so
plus 2 centimeters.
Definitely we will go with IVF, madam, in this
Madam,
case.
For you? What do you?
Yeah, same.
IVF? Madam? IVF? So nobody wants to do a lab? Okay.
No.
So is there...
Same.
Okay. So the question basically here is there an advantage of doing laparoscopy before you do a IVF? So I think even when Dr. Ashish had started this case also, that is the thing. She's had 3 IUI failures, but if she says that I am not going to get another cycle of IUI done after you do a lab, there is no point of doing a laparoscopy in that patient. In that patient, she did not even have an endometriotic cyst. You know, we just went inside the laparoscopy and incidentally found that there is pelvic endometriosis. If you do a laparoscopy, if you see that there is pelvic endometriosis, then at least after that, give her 1 or 2 cycles of IUI. Don't leave her alone and don't say that try naturally. Or at that point, don't say that, okay, I will go ahead and do an IVF now. So, lab in itself, although there are some studies which says that doing laparoscopy in failed IVF patients with endometriosis actually increase the success rates of it. I think the numbers of it are very, very limited. Doing an invasive and expensive procedure before you go ahead and simply change the course of action is not required. So it's very simple. If the woman is old and married for too long, if she's having an endometriotic cyst also, please go ahead.
Apurva, what about the fibroid there?
Yes, so the size of the fibroid is not mentioned. So I will come to that question in our next thing. But before I move on to my next cases, I have to. Dr. Ashish has not asked Dr. Ashish any questions.
Yeah.
So I have to ask him a question. So 21-year-old female with PCOS. They've been married for a year. The rest, everything else with the female is normal. The husband has had an undescended testis for which he was operated 2 years back. And even now, the semen parameters show azoospermia. How do we proceed?
Is it bilateral or?
Bilateral.
Bilateral. Okay, where was this testis there? Like, was it in the pelvic?
Let's say abdominal.
Abdomen. So there's no way that you can do anything for that, because it will be nubile testis for sure.
So let us say in case if it is in the pelvis and they kind of operate, is it possible for them to kind of operate at this old age and bring them down into the scrotal sacs?
It doesn't help for sure. But the guideline says that to remove that. Correct. Because the high chances of it becoming malignant.
Sure.
So if you still want to try something in this patient, check for the hormones.
So let us say if there is one testis which is descended in the scrotal region, and then other testis has been removed 2 years back, and even now they are in azoospermic space.
Again, just check for the hormones.
FSH is 12, LH is 11.
I'll try.
All of us are trying here. What are you going to try with?
I'll proceed with micro TSA.
So does
Ashish, my questions to you.
Ashish versus Ashish.
No, it's not like that. When you are talking about why micro TSA, why not a TSA?
Like before proceeding for micro TSA, I will anyways on table to a mapping TSA definitely. After that only I'll proceed for micro TSA.
Why I wished to talk about, because all of us are doing a micro TSA later. First is a TSA, testicular sperm aspiration we do. And if it is found out to be negative, then we go with the micro TSA. What is the importance of the micro TSA, what you thought of? Because we wish to know as a gynecologist, why micro TSA? Because we need to talk to the husband that these are the particular things you will be doing, that is a cut, you have to evert the skin and going for that particular micro TSA and the recovery, all that thing.
So only at the end of the day, we want to give them their own biological child.
Yeah.
So first we will definitely counseling about that. So you want your biological child, we need to go with this procedure. So again, so micro TSA is more better is what I think.
Yeah, but in micro TSA, when we talk about there is a pool of a spermatogenesis. We don't have a certain part of the testis. We have a fibrosis and another. That's why we do a micro TSA. We don't do a, like previously they just do a TSA or a biopsy. We do it with the microscope. Actually, what you see in the microscope is the tubules. How you identify these are the good tubules and these are the
so again by look of it, dilated tubules.
Yes.
First, always identify the dilated tubules.
True.
Never you can't pick up everything you see.
True.
So always go deeper layers, deep layers of the testis. There's high chance that we get dilated tubules.
I'm sure all of us have great andrologists who can retrieve the best of the sperms for us. So we will not get into too much in detail regarding that. Let us say if I am a gynecologist, I'm not a fertility specialist, I'm a gynecologist. I have a patient like this with me where the sperm parameters are showing azoospermia. And I'm telling the patient nicely, go to a fertility specialist, but she doesn't want to go because, you know, her generations have been with me and so on and so forth. Is there any one single test a gynecologist can do which will predict the possibility of, so the main issue in azoospermia is either we do an IVF with TSA or we go ahead with a donor.
Yeah.
So is there any one test that a gynecologist can do which will let us know where they will lean to?
Yeah, always better to see whether it's an obstructive azoospermia or non-obstructive. First basic thing. So if you think there is an obstruction by any cause, infection, mumps, or anything, just the general hormonal levels will be absolutely normal in this patient. If there is a non-obstructive azoospermia, the FSH will be skyrocketing. So if you still want to try in this, check for inhibin B levels. So that will give us more idea before going, telling anything. For the further procedures, you see inhibin. If inhibin is too low, still there is always a chance that we might still get it. Yeah.
See, you know, anything can happen. You know, if Donald Trump has become the president of US, anything can literally happen. So we are not looking about you know, exceptions. Yes. So FSH, LH, and inhibin B. I think these are the three tests that we can do, which will let us know what is the probability of success in a TSA. If you have normal inhibin B, low FSH or normal FSH and LH, that means that this patient is probably an obstructive and
so
has
always
better outcome.
FSH, LH below 7.
Yeah.
Nothing more than that.
Even if you found out the sperm, we are not here interested in finding out the sperm. We are here interested in formation of embryos. So before that, whether in which particular case of patients you like to do us as a micro deletion of the eggs, because azoospermia, one of the things that one should do.
Micro deletion, yes. If you think, if you check in the genetic levels, if you think that there might be a chance of micro deletions, just basic examination, start with basic, is the VAS is there or not. So after that only we can go ahead with genetic testing.
Okay, so now again quickly coming back to the clinicians. 28-year-old, 5 years married life. She's undergone a DHL 2 years back. Let's presume that she's undergone drilling also for PCOS. And now she's come back, her AMH is 18. How do we proceed? Madam, start. Where is your mic? So 28-year-old, married for 5 years, underwent DHL 2 years back for PCOS. Now the AMH is 18. Presume normal sperm parameters and normal fallopian tubes.
She's having regular cycles.
What will you do? 18 AMH, she's come to you, she says, I want to get pregnant.
I'd like to do ovulation
Please,
induction. I'd like to do ovulation induction.
Yes, we see these patients every day. Okay, you do ovulation induction, great. Will you do an IUI or not? Yes. You can be confident and tell that there is nothing wrong. It's been 5 years, she's already undergone a drilling. The first thing is someone who's undergone a drilling, if she's not got pregnant in 2 years, then it is actually the onus of the gynecologist, because drilling చేసిన తర్వాత 6 months వరకే LH levels తగ్గుంటాయి. తర్వాత దాని ఎఫెక్ట్ పోతుంది. So don't tell the patient that I'll do drilling and you go try naturally. You have to follow her up and you tell her that 1 year లోపల నువ్వు ప్రెగ్నెంట్ అయితేనే నువ్వు చేసిన డ్రిల్లింగ్కి యూజు, లేకపోతే నీ మనీ వేస్ట్. It is true. And you make sure that she, after drilling, it doesn't matter, you still go ahead, give her ovulation induction, and if in 3-4 cycles, if she doesn't get pregnant, there's no harm in proceeding and doing or recommending at least an IUI for her. Patient always has the option to refuse. But as her gynecologist, I think this patient definitely needs an IUI. I think I will, so we will be anyway discussing on myoma. So instead of going about a case that we have made, we are going to discuss the case that's given to her. So 1, 2, 3, 7 questions adugunnaru post myomectomy gurinchi. I'll just ask one by one what you guys do. Post myomectomy, anyone lab surgeons? Okay, sir, చేసేస్ ల్యాబ్ వేరే సర్జన్ దగ్గర చేసి మన దగ్గరికి వచ్చారు. షీస్ కమ్ టు యూ నెక్స్ట్ మంతే వచ్చింది. After how many months would you start planning for pregnancy? You be clear. You see what we can open. The whole point of this conversation is to.
We are discussing. We are not here to just what we feel. We also feel the same way. It's not something.
Yes, please.
We'll see the whatever the OT notes first, depending upon the size and the location of the myoma, how invasive it was, how much endometrium was damaged, or how much myometrium was damaged. So, depending upon that, we will wait for 3 months at least. And
3 months. You will wait for 3 months. Yes. If you open the cavity, not open the cavity, I will not go into that because it's become more than.
Very simple. I mean, obviously, there is a lot of literature and everything, but with a lot of endoscopic surgeons' consensus, if the endometrial cavity is not opened, and you have removed a subserosal myoma or a broad ligament fibroid or an intramural to subserosal fibroid, 1 month tarvata nunchi you can start planning pregnancy. 1 month, 30 days. If the cavity is not opened, if it's not a deep fibroid, you can go ahead. If the endometrial cavity is opened, that is when you need to wait at least for 3 months. మనం 3 months 4 months ల్యాబ్ తర్వాత ఇంకొక 6 months ఇది అయిపోయాక మిస్క్యారేజ్ అయ్యాక ఇంకొక 1 year 2 years ఇట్లా అంటూ వెళ్తూ ఉంటే వాళ్ళు ఏజ్ అయిపోతుంది. ఇట్ ఈస్ ట్రూ. ఒక్కొక్కటి చేసుకుని వెళ్తే ఇంకా అల్టిమేట్లీ దెన్ దే విల్ కమ్ ఫర్ ఎగ్ డొనేషన్. నౌ దట్ ఈస్ ఆల్సో బికమ్ వెరీ డిఫికల్ట్.
Last sentence repeat please so I can understand.
ऐसे करते अगर चले जाएंगे ना हर चीज़ के लिए फिर बूढ़े हो जाएंगे.
Adding to that point, you need to understand how much is the approximation of the two sides you are done. If there is too much of blood or if too much of space in the myometrial closure, then you require higher healing time. So those who are just observing the surgery also will come to know whether the surgery is doing very well or not. Even if it is open myomectomy or whether it is a laparoscopic myomectomy, the defect has to be sutured well. It is maybe a single layer or maybe a double layer. And what is if there is a pocket in between or maybe a bleeding in the medial, then you have to wait for a longer time. Yeah.
Okay. So madam, any special instructions when she is pregnant? Edana extra monitoring chestara? Yes or no?
See, I mean, post myomectomy there are certain complications during pregnancy we may encounter. Like we have to see placental location, and
Very good.
preterm chances of preterm.
So I think two things that we are worried about is one, placental location resulting in as a placenta accreta, or increta, or a rupture happening. Yes. So on continuing on the same topic, section or normal delivery.
We can try.
Still normal ante
always everyone do a section. There is a history of infertility, history of scar uterus. Only you require a lion heart to do.
Don't need a scar only.
No. But now there is already scar inside. Why you are talking about?
Why you are even thinking about? I understand the whole consensus of it. I understand there is idea of doing surgery just at maternal request. You really don't need an obstetric indication to kind of go ahead and do it. But technically speaking, if a patient comes to us and says that, okay, I've had a myomectomy and I want to do a normal delivery, logical ga alochiddam. Cesarean ke myomectomy ke difference evanna unda? Yes.
Definitely.
So yes, there is still, because it is a lower uterine segment and we are looking at if it is a fundal fibroid, it becomes a classical cesarean. Correct? This is the two differences. So location of the fibroid is what is going to matter for us. In case if it is a posterior wall fibroid, it is low down, or it is a corneal fibroid or lateral fibroid or something like that, and the cavity is not opened, you can still go ahead and give the patient a trial of labor. After 9th month lo, me sonologist ni, they can evaluate ekkada myoma scar undo, they can evaluate the thickness of it and then they can tell you. See, section koppeskunte manaku asal probleme ledu. The problem comes when she insists that she wants to have a vaginal labor. That is when we should be able to give a medical judgment for them.
I will add one thing to that.
Yes. Sorry, madam. Yeah. So that is again another thing important. You have to ask for the placental location and kind of ensure that there is no invasing abnormalities.
Yes.
And the placental location and the invasion of the placenta usually happens when we do a hysteroscopic myomectomies, where we are damaging the endometrium. If you are doing the posterior myoma and that suture is beautifully been done, how we are going to assess the posterior myometrium in the pregnant uterus and what is the length of the myoma? Can anyone answer me? I will be happy to enlighten with the knowledge. That is the first thing. And secondly, if we have I'm not saying that you should do a cesarean section. I will say there is definitely first we do a NST, then there is a tachycardia, fetal tachycardia, that is imminent chances of giving way of the sutures. All that thing we always, as an obstetrician, we know about it. But it is a per se that whenever there is a multiple myomas or multiple sutures taken, that is a high risk of a rupture. If there are multiple myomectomies in one, there are 3 myomas and 3 myomas are being removed, a higher chance of having the abnormal presentation, that is the first one. Secondly, chances of giving a rupture is
so I think
another
essentially
thing.
For all practical purposes, we should consider it like a previous LSCS and take it forward from there. They've asked if we can induce the patient. Normally, I think if Evita Fernandez ma'am was there here, she would have told, we'll induce everyone. But so for me, for VBAC, I have this thing that in case if they spontaneously go into labor, they have a non-recurrent indication for LSCS, we do allow them to go. So be very, very vigilant about inducing such patients for delivery. Okay, quickly, 32-year-old male, 30-year-old female, married life 1.5 years. Both are IT. I don't know why madam thought that it is important to mention that. AMH is 1.37, not used any contraception. Fibroids, 2 fibroids, one is 5 centimeters, another is 2 centimeters. Tubes normal. Semen analysis, 3 months back motility was 2%, now motility is 48%. How to proceed? So tubes are normal, AMH is 1.3, age is 30, 2 fibroids and currently normal sperm analysis.
I can answer that IT point.
Sorry?
I can answer that IT point because in a IT couple they usually have different shifts. Yes. One comes in the morning, another goes in the evening. So that is one of the things. That is the usually in Pune also it happens the same way. That's why that is the IT.
Within the same city is still all right. For me, I have couples who are in Bangalore and Delhi.
And they travel also. Only Saturday, Sunday.
Yes. Okay, madam, we'll start from this side. So what will you do next?
So location of the
Fibroid undi.
Fibroid
Intramural fibroids, fundal fibroids anukundam. They are not indenting the endometrial cavity. 5 centimeters, 2 centimeters, AMH, HSG, sperm parameters.
It's 2% has become 48%.
Yes, in 3 months. Is that possible? No. So it is possible that one of the labs has kind of given any variation which is there. Is it possible for the sperm parameters to also fluctuate or wave? Infection. So infection can be a reason. I think all of us would have seen that తక్కువ ఉంటుంది మెడిసిన్ అంతా ఇచ్చాక ఎక్కువ అవుతుంది ఇంకా వీళ్ళు ఎక్కువ అయిపోయిందని చాలా హ్యాపీగా ఫీల్ అవుతుంటారు అంత లోపల మళ్ళీ తగ్గిపోతుంది సో దట్ ఐ థింక్ ఈజ్ అ విండో ఫర్ అస్ ఇఫ్ సమ్మన్ హ్యాస్ హ్యాడ్ అ లాంగ్ హిస్టరీ ఆఫ్ పోర్ స్పర్మ్ పారామీటర్స్ అండ్ నౌ యు ఆర్ ఫైండింగ్ దట్ దే హ్యావ్ బికమ్ బెటర్ ప్లీజ్ నో దట్ మనకి తెలుగులో ఆరిపోయే దీపానికి వెలుగు ఎక్కువ అంటారు కదా
English, please, so I can understand. No, I hardly can understand as a Kumar.
बुझने वाली दिए का रोशनी ज़्यादा
है. Yes.
So रोशनी, हाँ, रोशनी ज़्यादा है. So please make sure that you catch that small phase that you have and make sure that you are using that time. Don't waste it. Even if you have to freeze couple of sperm parameters, we can go ahead and freeze them. Okay, let us say the first report was abnormal and ippudu 48% undi. For their sake, we hope it is now. I think the idea here is, should we proceed with the surgery or should we go for any treatment? Natural ga try cheyandi ani odlestama, treatment ki veltama.
So already 1.5 years, it's better she goes for treatment.
Yes.
And AMH is also almost borderline.
Yes.
So 2-3 quick cycles of IUI if she doesn't conceive IVF.
Ashish?
Yeah.
Moderator is asking moderator.
So this is a panelist and moderator now.
No, expert decision.
No, it's always
Yeah.
I enjoy it.
Yeah.
See, there is a AMH which is 1.2.
Yes.
Secondly, there is two fibroids. One is 5 centimeter and another is also 5, not distorting the cavity. The motility in the per se is very low. I will prefer this particular patient should go with the evaluation of the endometrial cavity. I will do myself with the 3D ultrasonography to know the endometrial, not only whether it is indenting the endometrium or not. I will see that a myoendometrial junction, because my implantation of the embryos happens at a myoendometrial junction and not in the cavity. So if they are not having any said that effect on the endometrium, I will go with the IVF directly. I will not get a time, because 1.2 AMH coming down to very fast. Maybe at this age it's 1.2. We never know. Maybe after 2 years she will land up into POI.
Sure. Okay, so IVF, again, as I said, it's a very individualistic decision as to, we can always offer patient will accept or not accept is a different thing. But the idea of a 5 centimeter intramural fibroid, it's not subcaesarous or pedunculated. I have had 2-3 patients, who have unfortunately had red degeneration in the pregnancy. They were initially just about 3 centimeters. They're 2 centimeters and 3 centimeters pre-pregnancy. And in pregnancy, from first trimester to second trimester, they increased to 8 centimeters. And she has significant pain. I mean, like pain wherein, it makes endometriosis feels silly. So, I think if the fibroid size is more, and I have heard Dr. Prakash Trivedi talk a lot of times wherein Sir has always said any fibroid means that it somehow will kind of result or affect infertility. So 3 centimeters kante fibroid ekku unte, and if it is not subserosal or pedunculated and it is there, we might counsel them and give laparoscopy. E patient ki right now IVF kante maybe we can kind of consider in terms of laparoscopy. See, this is 2 schools of thoughts.
No, I'll beg to differ here, because there are the 2 reasons. The fibroids are there. I think all gynecologists can vouch for me. There are the fibroids. How many patients you see with the fibroids and pregnancy going till term and delivering? Yes. We will not thought of them having the fibroids. At the time of delivery or maybe cesarean section, we'll find out there is a fibroid. So only having the fibroid per se, here definitely the factor affecting the infertility is low AMH and that poor guy.
I have one
that is,
point to add.
Who is adding? Yeah. Sorry.
Fibroid in this case, though we have the pregnancy in this, the continuation of the pregnancy we have to look for, because chances of pregnancy loss, though implantation can happen.
I will give a try, no, madam. If I am having so many embryos with me,
Okay.
why to add?
That's okay. As I said, I think you cannot ignore it. Let's say that. We cannot ignore the fibroid. I think, don't think that, I mean, I'll just take 5 more minutes and we'll wrap it up. Let's just not think that yes, exactly. So let's not assume that, okay, we know everything what is best for the patient. Do have this conversation with them, because it is going to keep you in a safer space. Because if, let us say, I do an IVF for the patient, it doesn't succeed, or she fails, or she aborts, I can't go and show her a trial and say that, you know what, it doesn't matter. She will show me another trial where it shows that it matters. So having that discussion with the patient, I think, is very, very important. Quickly,
This is the first time I agreed with her that we have to talk to the patient. These are the things. This may cause implantation failure and this may not cause. If you do a laparoscopy, I will ask all of you, if you do that 2 myomas removed and you have a beautiful blastocyst, you do a transparent that fails. You've taken the IVF effort, you've taken the money for IVF, you've taken the money for the laparoscopic myomectomy. Yeah. Madam, but it is not impacting on the endometrial cavity.
Okay, as I said, yeah, I think we get the point. So quickly, 23-year-old married life, 1 year, irregular, 45 kg weight to induced with letrozole for 3 cycles. Every time she's ovulated, and HCG was given. Semen analysis is normal because she didn't get pregnant in 3 cycles of timed intercourse. Now I have sent her to a fertility center. What else could I have done as a gynecologist? I think, sorry? Yes, I think any patient who's coming to you for pregnant, HbA1c, TSH and prolactin and CBC, minimum change. Because so many patients you kind of detect that they are thyroid when we get pregnant. HSG, tubal testing, I think, is something which you can definitely do. Prati month ovulation chesinapudu follicular monitoring ki every month pilvalsina avasram ledu, because that is taxing the patient. And yes, in case if you do have the ability, we can proceed with an IUI in this case. There was one more, I think, very interesting thing. Last 2 questions. How does PPOS prevent mitochondrial damage leading to miscarriage in a PCOS? PPOS, progesterone.
Yeah, progesterone prime protocol.
Yes.
Yeah.
So, when we are doing your IVF cycle, antagonist or agonist are suppressing your FSH and LH production so that there is no endogenous LH surge and there is no premature ovulation. You can use OCPs wherein your endogenous surge is completely suppressed. Like that only we can use progesterone also, which is suppressing the endogenous LH surge. So I don't think it is going to significantly...
there are the 2 things I think the question is that you are using an antagonist for suppression of the LH peak. And when you do a agonist cycle, you started from day 21 or maybe from ultrashort protocol day 1 or day 2 of your cycle. When you are using a progesterone prime protocol, the LH is not that much suppressed. They have an endogenous activity which has been maintained between 4 to 5. The LH surge is not going to occur, but the endogenous LH which is required for the initial activity of the granulosa cells to function on in a later follicular stage will be there. And that's why the mitochondrial damage will not be occur in that PPOS.
Sure. So the last question, I think someone has asked, how is a PRP prepared? I think PRP, if you have any hematologist friends or dermat friends.
PRP is prepared, if at all I can answer. There are the 2 things. You can take a 20 ml of the peripheral blood of the patient. You have to centrifuge it to the 1800 gyri for 10 minutes. After that, the buffy coat comes and you have to have a supernatant. You have to discard the supernatant and take the buffy coat. Again, you have to resuspend it and do a 1200 gyri. And then whatever is coming is a platelet. You have to see what is the pre-platelet concentration and post-platelet concentration. Anything which is more than 5 lakhs are good PRP. There is called as a temperature activated PRP, in which whatever PRP you make, or maybe a 2 cc or 4 cc usually we have, we had to do it in a cryoprotectant can just above the liquid nitrogen, and then because it goes to the minus degree centigrade, and then you thaw it as what we do it in the thaw FET. You have to temperature at 37 degrees, and this particular temperature change causes activation of the platelets, and this is called as activated PRP, what we do.
Thank you so much, Ashish, and thank you so much for all the panelists.
Thank you, panelists. It's been a wonderful audience for
thank you for
taking
all the
me
wonderful
and
questions.
her as a moderator. Thank you.